Three, two, one, go. Okay, my friends, glad to see you. I can see 7 persons in our chat room. You can write something like 3 pluses if you hear me and if you can see me. I will write something in our chat room. Welcome. Eight persons now with us. Gastric, right, hello, okay, hello my friends. Ahmed is here, Aisha is here, okay. Behind me. So, I think it's not typical to us to make some kind of live stream, live translation. Hello my friends, I can see all your comments in our chat room. Glad to see you. So, and because I think it's modern type of communication, it can be interesting to you, maybe more than even simple class. So let's check our sound. If you like sound of my voice, if it's loud and good, please write 3 pluses. Okay, like Aisha did. 3 pluses if everything is good with sound and picture in our live stream. We have also a little delay, I think, maybe 10 or maybe more than 10 seconds, a little bit. It's like a ping, little delay between translation and between recording. So everything okay. So it's very good. 9 persons with us, including me. So much better than in real class, isn't it? In our real class we have sometimes 2 students or even 3 students, but now 8. So very good. Let's start talking about something. I think that better choice today is talking about something like operative surgery of the abdominal organs. I think it's most practical thing, but I hope that today we will talk about theory, and then after epidemic measures we will return in our classes and make some practice, some surgery with internal organs, abdominal organs. Okay, so let's check my browser, let's check my presentation. I hope that you will see everything. So let's check that this picture changed now. Okay, so do you see something change? Isn't it? Okay, I can control this, and you even can see the I'm sorry, I can in this browser it's very difficult to use it online. I think my computer are very busy, and I hope that delay is not so long between us. Okay, so I think that we can check this information, we can check these terms, and then we can go to a different browser and try to find some pictures about these kinds of surgical treatment, and let's check maybe gastrotomy at first. So you can find at this slide information about gastric surgery. I'm sorry, I need to check the chat room. So a lot of pluses I see from Usman. Hello, my friend. Okay, let's continue. So gastric surgery. If you want, you can make a screen copy, print screen of this slide, or if you want, I even can share this presentation with you. I just make a link now. I will copy the link and give you inside our chat room. Okay, please take it if you want. You can download it or look at this text online in your browsers. So it's just a theoretical presentation without any pictures, but let's find some pictures about gastric surgery. At first, I think that we can take maybe gastrotomy. Okay, gastrotomy and gastrostomy. So maybe I need a few minutes to find these pictures in Google. Just wait a minute. Okay. Now I just check my Google pictures to find perfect picture about gastrostomy. Okay, I already find one. Okay, I will copy it. Okay. So let's check your screens and write something in our chat room if you can see the picture that I found, and I need to find another type of pictures. Just wait a few minutes. Okay. So I already find the picture and try to make a copy and paste it. Okay. I think now is a better way to look at this picture. So I will check also our chat room. Okay, thank you. Yeah, we can see. Okay, everybody can see this picture. So let's look at this picture. I hope that you can see the arrow now Okay, let's change color, and let's use red arrow now. So please look at this schematic view of the simple gastrostomy, like Witzel gastrostomy. Let's at first remember the terminology of this type of surgical treatment, surgical manipulation. We have stomach and different types of diseases, like maybe ulcers, like cancer, like bleeding from ulcer, like foreign bodies of the stomach, like many more problems, many more diseases. And in different cases, we need to choose different type of surgical treatment, of course. And most simple, term and most simple term in operative surgery is gastrotomy. So in Latin, I will write it in chat room. Gastrotomy. It's in Latin, and in English, gastrotomy, just the same. It's in Russian, gastrotomia. Maybe you can remember this term "tommy" from our previous classes, maybe from previous semester. It's always making incision of the wall of any organ, maybe hollow organ like stomach, and we need to make this incision maybe to remove some foreign bodies from stomach, maybe to make the continue of this incision, and then make the different type of surgery like resection of stomach. So it's most simple, but in our picture, in that picture, we can find next one. It's in case of gastrotomy, it's a little bit more difficult than gastrotomy because it's a surgical operation of the inserting tube inside the lumen of the stomach. Okay, inserting tube. So we make connection between lumen of the hollow organ and outside environment. So I told you maybe about tracheotomy. Do you remember? Tracheotomy is connection between the artificial connection between the lumen of the trachea and between the outside. So which help patient making breath. Okay, but in case of gastrostomy, of course, it's we can make this surgery because maybe we need to supply our patient with meal. If he can't or she can't eat simple meal, simple food, maybe because of different cases of pathology of the esophagus, like esophageal carcinoma, maybe when patient can't swallow even liquid, even saliva, and of course we need to use some different way how to insert food, insert a meal inside the stomach. So and digestion process can continue. So it's about gastrostomy, and of course, in case of operative surgery, we have different types of gastrostomy. How to make it? We can make it without any artificial tubes, without anything. Just we can use the wall of the stomach and make a connection, make suture between wall of the stomach and excess of the abdominal wall, inside the abdominal wall, through the wound. We can remove, release the stomach and remove it from abdominal cavity, from the peritoneal cavity, and make connection between serosa, using the seromuscular sutures, and between the skin, directly between the skin. And it's one of most simple type of gastrostomy. And about it, I will also say something later, because I need to download another picture. But now in that picture we can see a tube, rubber tube. In that case, in that picture, it can be rubber, but in real life now, in modern surgery, of course, it can be produced from some polymeric substance, plastic, rubber, composite materials, which can be sterile inside package. You need to just open this package, remove the sterile tube, and use it due to surgery. Okay, so let's find stage of this gastrostomy process, of the Witzel gastrostomy. So first stage, it's making the access. Of course, we need to make access to the abdominal cavity through the abdominal wall, maybe median laparotomy, superior median laparotomy, and later we can take the anterior surface of the stomach, anterior wall of the stomach, and we need to put on this surface the rubber tube or drainage, So we can put the tube on the surface, and using the intestinal techniques of the intestinal suture, we need to cover this tube with serosa of the wall of the stomach. Okay, we need to make a tunnel. It's like a tunnel. So I will try to draw this schematic section of this structure using red color, and I need to take some brush or some shape like that, like this circle. Please write 3 pluses if everything okay, if you still hear me and it's interesting to you, and you understand all this, you can understand all this information. I will check the chat room. So 4 pluses, even 4 pluses. Okay, it's perfect. One, two, three. Okay. 3 persons write that. It's good. Oh, 5 persons. Okay, great. So let's continue. And let's try to draw the schematic view of the section of this region. I just also use the brush, and so let's draw the section of this surface of this region. Okay, so this circle is tube. I also will try to draw maybe little arrow here, and try to write that this thing is tube, or drainage if you want. Drainage. Okay. let's scale it a little bit and make it bold. You can see it better now. Okay, let's try to continue. And what we gotta do? We gotta draw the mucosa. Oh, I'm sorry, not mucosa, but wall of the stomach. Let's use the green color, and I'm sorry, how to escape from text editing. Wait a minute. Okay, now I escaped. So so let's use the brush with green color. This is schematic view of the wall of the abdomen. Okay, so we need to make some fold and cover the tube, cover the drainage. Okay, so it is still wall of the stomach. So green color, it's a seromuscular layer. So if we try to complete our image, our schematic view, so this orange color can be the muscular layer. So green layer is serosa, and this one is muscular. Very schematic. I hope that you enjoyed the schematic view. So and then what we're gonna draw next, of course, the mucosa and submucosal layer. So I hope that you already understand this, and maybe our submucosa and mucosa must be a little bit thinner. Yeah, submucosal layer. So very schematic. We just take folds, take the part of the wall of the stomach in folds, and cover using these folds. We need to cover the tube. Okay, make the tunnel. So I told you about the tunnel. Here it is. Here it is. So, and we forgot the mucosa. It can be a blue one. Oh, I'm sorry. I drew the arrow, not the mucosa. So this one is mucosal layer. It's inside. It's difficult to continue drawing here, but of course you need to understand that mucosa is not stop here. It's of course continue inside these folds. So, and let's draw the last thing. Last thing is suture. Okay, so it's very big, very thick. Make it smaller. So this is schematic view. The circle, it's mean that this is the suture. Let's add some kind of mustaches, you know, to this suture. So this suture is suture the same, you know. Sorry, it's not so thick. Here it is. So this suture is schematic version of that row of sutures. Okay, it's the same. So, and here, after making this coverage of the tube, we need to make these rows. Maybe you can find 5 or from 4 to 6 separated sutures. Okay, and after that, after making the tunnel, some kind of tunnel, we need to release the distal part of the tube, and then we need to make the incision of the wall of the stomach here, in right here, near the distal part of the tube. So, and we need to cut using the scissors maybe, or cautery, we need to cut the wall of the stomach, and making the insertion of the tube inside the lumen of the stomach, like in that picture. Okay, so here we can find the insertion using the thumb forceps or tweezers. We can find the insertion of the drainage tube inside the lumen of the stomach. Okay, so, and before that, we need to make this kind of suture. I don't remember the English name of this suture, but in Russian I write it in the chat, directly in chat room. Кисетный шов. Just you can wait a minute. I I will use my Google Translate. Кисетный. Wait a minute. Okay. Translate. So ta-dam.
Pouch.
Okay. I even use voice or the Google Translate. Pouch. I will insert this name of the sutures inside the chat room, and duplicate it in English. So it's like pouch, and let's return to our picture. Let's use the arrow. So pouch sutures here we can see, and after invagination of the tube, insertion of the tube inside the lumen of the abdomen, we need to yes, pouch suturing, yeah, we need to tight this pouch sutures. Okay, tight it to close this wound, this section, this incision inside the wall of the stomach. Okay, so, and after insertion we need to make the additional sutures like that. Okay, just seromuscular intestinal sutures. We need to cover these pouch sutures. So pouch sutures is location of these sutures only near the incision of the stomach wall, near the distal part of the tube which we insert inside the lumen of the stomach. So, and then we need to cover this first row, this pouch sutures, covered by with the simple intestinal sutures, seromuscular sutures, Lambert sutures. Okay, so here it is. We can find the one of the stage of this surgical operation without tightening now in that picture, and after that we need to tighten it in. It must be look like this row. Just we need to continue this row. Okay, and cover this distal part of the tube with pouch sutures. So, and after that we need to make the counter aperture inside through the abdominal wall, additional aperture, and we need to retract our tube, free distal proximal end of the tube, and then we need to escape this tube through this aperture, additional aperture. Okay, and then we can connect with additional suture, make the connection of the tube and skin. It's just the fixation to hold it tight, okay? Because some patients, crazy patients, can remove it, can retract it, okay? So let's check the chat room. Mucosa is not included in the second suture. In the second row, you mean? You mean that mucosa is not included in the second row of the sutures, isn't it? Only outer layers of the abdominal wall. Okay. I think that I can understand your question. So I will try to make another picture using the same instruments. So look, it's different projections. So this one, it's you know, it's like a slice of the cross section of this operation in that projection. So we just make the cut, and we will find this thing, okay, this picture. So but now I want to make another slice, another cross section in different projection. If we make the axial cut and a different projection like that, so let's try to draw the tube. We can see in fourth figure, for a second, third, fourth. Yeah, you mean this that region, yeah? Of course, these sutures involve only the seromuscular layer. It also can involve the submucosal layer, okay? But of course, it's not involved the mucosa. So this patch suture also involve only the serosa and only the muscular layer, without you know, mucosa at all, without mucosa. So I want to draw the drainage tube and try to draw the schematic view of this operation. So this thing can be drainage tube to us. Let's change the colors. It can be green. Okay. Drainage tube. So let's add some volume to this. Oh, I forgot about this perfect thing. I can use it. So, oh, it's not so easy. I forgot how to use paint, and I can't use some modern software because I can't open it with software to make the video recording, to make the live translation. This software can't open the Photoshop and other programs for compositing and drawing. So, and because this I using the paint. So this drainage tube, maybe I can draw schematic view of this tube. So here it is. This orange line must be part of the stomach, okay? Part of the stomach, surface of the stomach, I mean. So let's make the muscular layer. Okay. So what's wrong with this? What's wrong with this thing? Okay. So it's very schematic. It's these pictures. This picture mean that tube laying on the surface of the stomach. So this is schematic view of the wall of the stomach, and this green thing is drainage tube. Okay, and here we can find the incision, the same one, like in that picture. We make the incision and make the insertion of the tube. Okay, insertion of the tube. So, and in case of the sutures, we need to continue our picture and draw the thick line. This is submucosa. This one, and another one must be the mucosa. Very schematic, very schematic. It can be yellow. So, and what we need to do, we need to cover with sutures and with mucosa. We need to make the tunnel here. Do you remember about that? I will take the brush and try to just make a few lines. That mean that we need to cover this tube with our wall of the stomach. Very schematic. So, and we, of course, we make the sutures here. So, sutures, a lot of row of sutures. So, and what we're gonna do now, we also add sutures here, schematic view of the sutures. It's pouch suture, okay, and we need to tighten it, okay, very close. I will draw some kind of arrows, which mean that we need to tighten it. I hope you can understand my creativity. It's look ugly, I think. I think you can't understand something here. Okay. Anyway, we need to cover this pouch sutures with also with cerebromuscular layers. I think that you already understood all of this thing, but we need to cover it and add another row of the cerebromuscular, only cerebromuscular sutures, without any mucosa, without involving all the mucosa. So, oh, it's so thin, very thin ligature, isn't it? So, we just will cover it. Okay, so you can see that yellow line and oh, it's already orange here. So this yellow line is not involving at all. It's not involving at all. So, okay, I hope you understand this visceral gastrostomy. And let's take another picture. Let's take another picture. Yes, understood. Okay, great. Let's take another picture. I need to power off my camera now. Okay, and I want to increase the scale of the drawing. Increase the scale of the drawing. Okay, just wait a minute. So, I think much better. now what we gotta draw? We gotta take the different type of gastrostomy. So let's try to insert this picture. Please look at that picture. This also schematic view of modern gastrostomy. So we can use just the endoscopic techniques with modern drainage, with some kind of balloon at the end of the drainage, and we can enlarge this balloon inside the after insertion of the tube inside the lumen of the stomach. And I'll try to take the arrow. Oh, maybe green look better. So we can use the same techniques like synthesis, using the trocar to make the puncture of the walls of the abdominal layers of the abdominal wall, and insert the tube and make the puncture of the wall of the stomach. And then after inserting the tube, we can enlarge this balloon inside to lock this tube inside the lumen of the stomach. Okay, and it's not so invasive like Witzel gastrostomy or other types. Right, this drainage pipe with balloon do not need suturing. Yes, it is in different cases. In some cases we don't need the making the fixation, making the suturing of the drainage tube to the skin, but in most common practice we can find different patients, also maybe even stupid patients, that want to remove this tube, and they try to retract it, and it by the way to make the fixation between the tube and the skin, because if we don't make this, patient can make the wound, can injure the wall of the stomach, okay, and make the perforation and make the peritonitis maybe. So I want to download another picture to you. It's a picture about modern techniques, but I want to find old technique of the gastrostomy. Okay. Just wait a few minutes. So okay, now I just find the picture, good picture about this type of gastrostomy. So I just copy the picture and insert it. So write something in our chat room if you can see this type of gastrostomy, and I will try to say something about this old type of surgery, old type of gastrostomy. Okay. So let's also draw arrow, can be white here. This left side of the picture is about the access to the stomach. You need to remember all layers of the abdominal wall to make this access. But what the main thing and what the main difference between previous type with tube? We can see any tube here, only wall of stomach, which we retract through the surgical wound to the outside, directly to the skin. So we need to make few rows of the sutures, circular rows of the sutures, you know, here, and we can use the part of the stomach to make the natural tube, you know, that we produce from a wall of the stomach. So I will try to draw the schematic view. So if this is schematic view of the cross section of the stomach, just round circle. So we can take, to make this type of gastrostomy, we can take this part of the wall of the stomach and make a tube. So let's draw with gastrostomy. Okay, you can understand that we just need to make some rows of sutures here. Here it is. 3 rows at least. Rows of sutures. So I use different color. First row here, and we need to tight it. It's also like pouch suture, okay? Like pouch suture. In Russian language, kiset. And the last one here. So we make some kind of natural tube using the wall of the stomach. So this one is the lumen of the stomach, okay? Also, we need to make the incision here, and we can find that here, this guy using the scissors making the incision here. And after that, we can take the serosa and connect the serosa directly to the skin here. Add few sutures here and here. So, but it's not so modern. It's I think it's more historical type, because imagine that this that stomach have connection with skin, directly with the skin. All consistment of the stomach with acid always will irritate the skin, okay? Always will irritate the skin. So I need to return to the screen. Just wait a minute. I need to return to the screen. So write some comments in our chat room if you understand this old historical type of gastrostomy, Toprova type. It's Soviet scientist, Soviet surgeon, Toprova. So you also can see his name in Russian language here in upper part of the picture, Toprova. So yes, we understand. Okay, perfect. So I think that we should take maybe another type of gastrostomy and talk a little bit about that, and then I just please repeat again. Repeat about what? Repeat about this type of gastrostomy, Toprova. So, difference between previous Witzel and between Toprova is using the part of the stomach to make the natural tube. So, in Witzel gastrostomy and in other type like endoscopic gastrostomy, we will use artificial drainage tube, okay? Artificial tube, rubber or other material. But in case of Toprova, we need to make the same tube using the wall of the stomach, okay? Okay, so I talked about my presentation in the first part of our stream, and I told you about that we have a lot of different organs in abdominal cavity and a lot of kinds of surgical treatment, and in our stream we talked only about gastrostomy a little bit, and I want to return to the browser. I want to return to the browser, and I must be sure that you also see this browser. You see it too? Okay. Wait a minute. Okay. Okay. So let's find something in that picture, in that presentation. So now we talked only about gastrotomy and gastrostomy. So we also here in that, even in that picture, can find many more types of the surgery, and I will paste this image. I will paste this image and return the paint interface to the stream. Now let's also wait a minute. Okay, so let's try to understand something about next thing. Please look at this arrow. It's very thick to us. Okay, so we talked about gastrotomy. It's just the making incision of the wall of the stomach. Okay, gastrostomy is making connection between the lumen of the stomach and environment, outside environment. What about gastric resection? Resection is, of course, the deleting of some part of the organ of the stomach, deleting the part of the stomach. Okay, I hope that we will have practical class about that theme, and we will make practice. We will make the gastrostomy, and we will talk about gastric resection and other types of surgery more in maybe high level, you know. No, but not now, because we now have a lot of time, and I think that I think it's a good way, this online stream, to take the simple information about clinical anatomy, but of course the most complex and difficult part of our knowledge, we need to talk about that only in our department, using the illustrative material and cadaveral material. So gastric resection is deleting of the part of the organ. So what about gastrectomy? Do you remember something about ectomy? It's deleting of the whole organ, in which cases we delete the stomach parts. Okay, we make the gastric resection. In case of ulcers, and in case of some complications of ulcers, like maybe penetration and like bleeding from ulcers, which we can't stop using less invasive techniques like endoscopy. So we also make gastric resection, can make gastric resection in case of malignant tumors, but in case of malignant tumors, now today most oncological hospitals using the strategy to make the gastrectomy. So maybe resection we can make in case of first stage of cancer disease, of the gastric carcinoma, when we can be sure that in that case your patient don't have some metastasis into the lymphatic nodes. So what else? Gastrectomy is total deleting of the stomach. Okay. And I told you now about oncological gastric surgery. So in case of malignant tumor, it's operation, surgical treatment number 1, gastrectomy, deleting of the whole organ, whole gaster, whole stomach. Okay. So what else? Gastroenterostomy. Gastroenterostomy or gastroenteroanastomosis. It's making the connection between lumen of the stomach and between the lumen of the small bowel, small intestine. In modern surgery, it's not so frequent. It's maybe it can be like a part, like a stage of the gastric resection. So after resection, we can make the gastroenteroanastomosis. But in last part of 19th century and first part of 20th century, it was a very popular surgical manipulation, gastroenterostomy, to treat the ulcer diseases. Before scientists open the etiology of the ulcer disease and as etiology of the gastritis, any gastritis, and today, of course, we know and we understood that we need to treat the Helicobacter pylori at first, conservative. We can treat it conservative using the eradication, using the antibiotics. Okay, but in first part of the 20th century, and I think in all 20th century, only surgeons treat the patient with ulcer disease using the resections, and in first part of 20th century they used gastroenterostomy. So they thought that in stomach we have a lot of acid, isn't it? A lot of acid, but in thin bowel because of pancreatic secretion and because of production of the I'm sorry, of the bile. Of course, the environment inside the thin bowel, it's almost like like alkaline. Okay, so alkaline, closer to alkaline environment inside the thin bowel, and more acid inside the stomach. Okay, so and surgeons thought that these alkalines will go through this artificial connection with artificial connection of the stomach and of the thin bowel, and this alkaline goes to the acid environment of the stomach and reduce this acid, and they thought that it's best treatment of the ulcer disease. Okay, so but it's, of course, it's wrong. It was wrong, because now we understand that it was just Calicobacter pylori. Okay, okay, let's try to return me to the translation. I will return my face. So let's check other points. Okay, and we also can see the gastropexy. Gastropexy is just the fixation of the stomach to the parietal peritoneum. I think that we will talk about this. It's not so frequent to meet this type of surgery, gastropexy. And gastrorrhaphy is making the sutures after maybe gastrotomy. Okay, you know that we have gastric surgery, and we also have small intestinal surgery, hepatic surgery, you know, bile duct and gallbladder surgery. So, but today I think it's enough to you, and I told you that a lot of information, it's like a lot of food. Let's try to not vomiting with this knowledge. So what you get now. Let's try to check our chat room. Gastroenterostomy is also deletion of some part of stomach. No, no, of course it's not deletion. It's not deleting. Okay, it's connection. It's making connection. I will try to. Oh, I already closed the paint, and I try to just to give you an answer. So gastroenterostomy, it's not resection. It's not resection. Gastroenterostomy, it's just making connection. So I told you about gastrostomy. Gastrostomy is making connection between lumen of the stomach and outside environment. But in case of gastroenterostomy, it's mean that we making connection between lumen of the stomach and lumen of the small bowel. Okay, without any resection, just connection, making the anastomosis between. You did the anastomosis in our practical class about intestinal suture, but you make the enter anastomosis when we use the 2 loops of thin bowel. But in case of gastroenterostomy, we use 1 loop of thin bowel and stomach, okay? And make connection between this. So, when is gastropexy done? So, gastropexy is operation of the fixation of the stomach when after mobilization, after complex surgical treatment of some diseases, cancer disease maybe, after resection of big part of organs, of abdominal organs, and dissection, reducing the ligaments, we need to make the fixation between wall of the stomach and parietal peritoneum to reduce the mobility, pathological mobility, because if it have very mobile structure, it can rotate, you know, it can you know, we can meet the ischemia of wall of the stomach after rotation. So okay, I think we need to finish our lecture, isn't it? I hope you enjoy, and it's modern to me because it's my first live stream in English, and I'm not the teacher of the English language. I hope you can understand me. So I think that we have contacts in WhatsApp, and let's try to understand about our next classes a little bit later. Just contact with me, okay? So I think that's all. If you don't have some questions, it was a good lecture. Okay, thank you so much. Thank you so much. Namaste. Ассаламу алейкум, my friends. Спасибо большое. Всего доброго. Goodbye.